So learning curve for someone who's a direct anterior surgeon, I would say a few cases, 3 cases, say, in all honesty, to get used to what the outrigger feels like, to get a little bit comfortable in where to put the incision for your cannula. After that, I think they would probably start to say, I probably don't need to make this big, long, longitudinal incision. They would start making it smaller, and that would probably be another 3 to 5 cases. I think this technique is really ideally suited for the person that is a direct anterior surgeon and is now just looking for the next evolution or the next level that they can take their surgery to. I think anterior path is where that fits in.
You know, with any new technique, as soon as you start doing it, your first couple of cases, there's going to be a little bit of a learning curve associated with it. I will say, after having done anterior approaches already, the learning curve switching to the anterior path approach was very minimal. 1 or 2 cases at most, just to get used to using the cannula instrumentation.
It was 1 or 2 cases, and it was me and my reps, and then some of the other people started thinking about the big picture and saying, like, this is really significant. Like, we're saving a lot of tissue here. This incision's so much smaller. Having an incision that's kind of comes across that deeper dissection doesn't make a lot of sense. But I'll tell you, as soon as we got to a cadaver, the first one I did, I opened up and I said, yes, this is perfect. Not only is it easier to get to the femur, but all you have to do is just open up this window and you're doing the same exact procedure. So I think a lot of people will eventually get there. It's just going to take sort of a paradigm shift in how we treat the soft tissues around the hip.